At the risk of sounding a little biased, right? I would say PARP inhibition is the impact of that. Like yesterday, when we were hearing about PROpel and magnitude data, I think the impact is going to grow with those trials as they translate into clinical practice eventually. There are many questions. So one is just given the side effect profile of PARP inhibition and the average kind of patient clinical characteristics of our patients with prostate cancer, I think it'd be hard to give them longer duration PARP therapy. For example, to move it up in hormone-sensitive space and give it for many years, I think that's going to be a very big challenge. So I know that space is empty, but it may be hard to move it up unless we do creative things. So the biology does allow for us to do interrupted PARP therapy. And that's not being explored just yet because the field is still evolving. But I think that would be one way to cut down on the grade 3 AE rates we saw yesterday from Olaparib and Niraparib and still come to the same conclusion in terms of efficacy. So I think that would be one of the ways to improve adoption of PARP inhibitors. And then as more and more of these agents get used in the first-line mCRPC setting, question arises, can you sequence them? Can you still get some benefit in a small subset of patients in second line and onwards? And I think those questions remain unanswered.